Welcome to week 9 for hematology. We will have 2 PowerPoints to go through today, so let's go into those here. All right, so the first step is going to be a PowerPoint on thrombocytopenia and thrombocytosis. I'm just going to skip through the couple objective slides for now. But any sort of bleeding disorder, remember, we categorize whether it's going to be due to the primary hemostasis system or the secondary. So again, the primary is all about the platelets and blood vessels, and this is what we call a mucocutaneous bleed. If we are having an issue with our platelets and they're not either properly functioning or there's too low of a number. So it's either quantitative or qualitative kind of defect. So again, signs of mucocutaneous bleeding are more like surface kind of signs, which is like petechiae, purpura, ecchymosis, epistaxis, and that's a hard word for me to say, gingival bleeding. So anything kind of more surface bleeds. And then again, if it's a secondary hemostasis disorder, which we had talked about last week, that would be more the deep tissue bleeding, and again, due to some sort of clotting factor deficiency. So one of those coag proteins are involved. So again, some terms related to bleeding. We've heard these a few times now. Let's properly define them. Petechiae are very small pinpoint hemorrhages on the skin surface. They're about 3 millimeters in diameter, whereas purpura look about the same. They're just a little bit bigger. And then ecchymosis, bigger yet. Ecchymosis we just would commonly call a bruise. And then epistaxis is your nosebleed. So here's what petechiae and purpura look like. Again, very similar. It's just the size of them that's different, but both are indicators of mucocutaneous bleeding. So thrombocytopenia is the term that means a decrease in platelets, and this is probably the #1 cause of somebody's bleeding, especially just mucocutaneous. There are lots of reasons why you would have a low platelet count. It goes along with a lot of different disorders. It could be anything from decreased platelet production, so you're just not making enough, accelerated platelet destruction, they're getting destroyed too soon, or just abnormally distributed in the body. So we'll go through all of these categories and why something would result in a thrombocytopenia. So starting with the decreased platelet production, this, of course, is going back to that megakaryocytes are producing your platelets from the bone marrow. And so if you were to have megakaryocyte hypoplasia, meaning a reduced number of megakaryocytes, then, of course, that would lead to a reduced number of platelets. So there's a number of reasons that could be happening. Maybe it's a leukemia happening that's kind of crowding the bone marrow, and so there's not enough room for those megakaryocytes, so it's dropping the number of platelets being made. It could be an ineffective thrombopoiesis, so an ineffective platelet production process, something like that. So there is a congenital megakaryocyte hypoplasia, so something that is hereditary. It's linked to a number of congenital disorders. So, for example, Fanconi anemia, May-Hagelin. We've talked about May-Hagelin briefly at the beginning of this quarter. And remember, that one is the one that's the triad of Dolly-like body inclusions, thrombocytopenia, and giant platelets. Again, that's a hereditary disorder, so part of that leading to the thrombocytopenia is not having enough megakaryocytes in the bone marrow to make them. Other examples are listed there. I will not test you on any of these, except you still have to, of course, know May-Hagelin because we've learned that. And Fanconi anemia, we actually learned back in Heme 1 with the bone marrow disorder chapter. So other than those, the rest of these, Sebastian Fechner, Epstein, these are all just mentioned. We are not going to have to test on these, though. Neonatal hypoplasia, there's different infections that can happen that will cause a decreased platelet production. So just kind of a side effect of those infections. So that's just kind of a mention here. And then other conditions, if you're taking different drugs that are kind of attacking, different parts of your bone marrow, like leading to hypoplasia. Megaloblastic anemia, remember in that one, which we learned in Heme 1, that is the one where they have inability to have proper DNA synthesis for cells, so everything was low. It was a pancytopenia. There was not a proper production of anything really. So, of course, platelets would be included in that. I mean, I know it's an anemia, and we've linked it well with red cell stuff, but because all 3 cell lines, white cell, red cell, and platelets are low, it still has a part of leading to thrombocytopenia for here. So going into the next category would be increased platelet destruction. So there is going to be a couple diseases here that we definitely need to know. Categories of increased platelet destruction could be due to an immunologic response. Again, that's going to be an antibody deal. So anytime you see the word immunology, you should right away be thinking antibodies are involved. Or it can be caused by mechanical damage. All right, so we will start with our first one called immune thrombocytopenic purpura, ITP for short. You can kind of change that I out. It can either be immune or idiopathic. Immune tells you, again, antibodies involved. Idiopathic is just the word that means unknown. Sometimes they're not always quite sure why this results. Sometimes they can link it, and other times they can't. So, but ITP is definitely a disease that we have to know. This is something that we need to walk away and know. So we have two versions. We have acute ITP and chronic, which will be on another slide here. Acute ITP primarily is more in children, and so they'll all of a sudden get this abrupt onset of bruising, petechiae, any mucocutaneous type bleeding seen. And usually it's always linked to a viral infection. So if that child that had some sort of virus, whether it be like a GI virus, like kind of like the stomach flu or something, maybe it's chickenpox or rubella or something like that, and they're starting to kind of recover, or like it's after they've already had that for a little bit, then you might see all of a sudden this acute ITP set in. And what it is the antibodies that you have made with that virus being present that you were using to try to fight that virus are now also targeting and binding onto your platelets and destroying them. And that's what all of a sudden results in your low platelet count and then the mucocutaneous bleeding resulting. So what I should say about this before we move on is it will go away on its own. It's just something that we monitor, and we just kind of watch that platelet count, make sure it doesn't get so low that they would need like a platelet transfusion. But typically it will just go away on its own. It will take care, run its course, and it will be done. Whereas chronic ITP is more any age. So acute was kind of more children, chronic can be any age, adults. So again, same sort of bleeding symptoms, mucocutaneous bleeding, all of that stuff. Again, it's due to antibodies attaching to platelets and destroying them. So this one isn't as easily linked as the acute one with the virus deal, but so that's where the idiopathic part kind of comes in. All right, so there's a look at ITP. Again, you're only seeing one field, but this would be a representation of all the fields. So when you're looking at it for platelets, you only see one platelet. That's over here at the left side, and that's just actually it's a giant platelet. But otherwise, there's no platelets really present here, and so you would see very low platelet count throughout your fields. There are different drugs that, of course, can result in platelet destruction, some of the quinine drugs, the penicillin drugs. I'm not testing on these ones. There is going to be one that I want you to know, and that is heparin at the very bottom here. That is the only drug I want you to remember at this time that does cause thrombocytopenia. So people are often placed on heparin as a blood thinner, which we have kind of seen with, we use that APTT test to monitor heparin therapy. And so a side effect of that heparin therapy is it will destroy and kind of the platelet count, and so the platelet count will start to drop. So a lot of times when somebody is on heparin, we will monitor their platelet counts to make sure that, again, they don't get too low. So that is one that I do want you to keep in mind. And then other things, non-immune causes would be like pregnancy, HDN, which is hemolytic disease in the newborn. You learn about that in blood bank. Here's one, TTP. We have heard of this back in Hematology 1. We need to relearn it and know it again. So it stands for thrombotic, which tells you there's clots involved. Thrombocytopenic purpura, and purpura, again, just a sign of mucocutaneous bleeding. So we first learned TTP with the MAHA group in Heme 1. Remember that MAHA group included DIC, TTP, and HUS were some of the three big ones out of there. And MAHA is, again, where you have those clots in the smaller blood vessels throughout the body causing hemolysis of the cells as they try to go through. Well, part of that is you also have thrombocytopenia. You're kind of using up your platelets in those clots. So that's where the name of this comes from. Thrombotic for the clots, thrombocytopenic for low platelet count being used up. The big deal with TTP is there are some neurologic abnormalities, and that set this one apart from the others. The others didn't have any neurologic abnormalities with it, but this one does seem to have that. Now, all of your normal coagulation-based testing like PTT, PT, D-dimer, all that are pretty normal. it's really just the platelets that get involved in this one forming those clots. Whereas in DIC, which we learned last week, that one was huge with everything was involved making the clots, fibrinogen, all the proteins, all that. So that one, everything was out of whack for testing, whereas this one, it's just the platelets that get involved. So there's really none of the actual coag tests that are going to be abnormal, other than a low platelet count, and then that would prolong your bleeding time, of course. So here is TP, again, because it's a hemolytic anemia occurring inside the blood, so an intravascular hemolytic anemia, you will see schistocytes and keratocytes, which are always signs of intravascular hemolytic anemia, which is what the cells are kind of pointing to, schistocytes, or the arrows are pointing to, excuse me. And again, but low platelet count as you look through the fields. Another non-immune mechanism is hemolytic uremic syndrome. So again, coming out of that same MAHA week, the big difference here, again, is that it'll have much more severe renal failure. There's some renal damage in TTP, but not as significant as what we see in HUS. So much more severe renal failure. And then again, TTP had the neurologic abnormalities, whereas HUS will not. HUS is usually resulting from a food poisoning type situation, especially either Shigella or E. coli 0157. When you get into micro, these will make more sense. You probably have already heard of these, but you'll learn of these more. But both of those produce a toxin that's very similar to each other and causes extreme damage and results in this bloody diarrhea, hemolytic uremic syndrome type issue. And then, of course, DIC, which we heard of last week. We already learned that. We know that all the platelets get used up in those clots. So, of course, that would result in thrombocytopenia. All right, and then finally, a disorder related to distribution abnormalities. So, way back in Heme 1, we have learned that the spleen will hold and store about 1/3 of our platelets at any given time. And so, depending on what happens with the spleen, will affect your platelet count. So, if you have splenomegaly in which your spleen becomes enlarged, now they're going to start storing way more than 1/3. They have more room, there's more things that they can store. So your platelet count in your blood will become low because now you're putting more into the spleen than it was normally doing. So that's what would result in thrombocytopenia there. And splenomegaly goes with lots and lots of different conditions. All right, let's flip over to the opposite side, the thrombocytosis, increased platelet counts. So you have what we call secondary or reactive thrombocytosis. That is basically meaning you get an elevated platelet count due to some other condition occurring in the patient. Maybe it's inflammation, trauma, something. So there's no really change in their function or anything. Their platelet count just elevates as a secondary response to whatever else they have going on. And of course, those myeloproliferative disorders, you know, essential thrombocythemia, polycythemia vera, both of those had very high platelet counts, especially essential thrombocythemia, that was extremely high. So we definitely see thrombocytosis with a couple of those. So there's a great example. Look at all those little platelets in that field. So that's a lot of them in that one field. So that's a good example of thrombocytosis. All right, I did have some couple review questions here. I actually forgot I had these. So you can pause this, try to answer them, and then, you know, restart to see if you're right. So thrombocytopenia may be caused by all of the following except, and in this case, it would be post-splenectomy. So again, a low platelet count would be definitely caused by chemotherapy. That's going to pretty much cause all your counts to be low. Decreased thrombopoietin. Remember, thrombopoietin is the hormone that is made by the liver that goes and helps make sure your platelet line is getting produced in the bone marrow. So you need that. If you don't have thrombopoietin, you won't make platelets. Aplastic anemia, remember, is bone marrow failure. So if your bone marrow is failing, well, you're not going to make cells at all, really. So that would, of course, result in a low platelet count. So post-splenectomy, remember, if your spleen holds 1/3 of your platelets and all of a sudden they remove the spleen, all those platelets that were trying to get stored are now floating in your blood, causing an increase in platelet count. So that's why that does not fit. So again, the answer was post-splenectomy. A 4-year-old is seen in the ER with petechiae and a platelet count of 15. She has no previous history of bleeding problems. 3 weeks earlier, she had chicken pox. Physician advises the child to stay off the playground to avoid injury, and the child will recover within several weeks to a month with no further treatment. What condition? And so this would be a great example of ITP. So the second answer there, ITP. Thrombocytosis is a characteristic of, and this answer would be PV, polycythemia vera. Remember, in polycythemia vera, every cell line is up. Everything is increased. TTP is characterized by, and it would be increased platelet aggregation. Again, TTP has nothing to do with the coag test, so PT and APTT would be normal. Those would not be affected. And remember, the middle word of TTP is thrombocytopenia, which means low platelet count. So it can't be thrombocytosis, but you do get those platelet aggregates or platelet clumps occurring, clots. So that would fit, increased platelet aggregation. Thrombocytopenia may be associated with, and this would be, talked about this a little bit earlier, hypersplenism. So that splenomegaly, all of a sudden storing more platelets than you're supposed to be, resulting in a low platelet count in the blood, so hypersplenism. Which of the following is a characteristic of acute ITP? So acute ITP would be spontaneous remission within a few weeks. Again, it's just going to kind of go away on its own. We don't really need to treat it, we just monitor it. TTP differs from DIC in that, there's a lot of initials here, I know. So this one, actually, I gotta make sure I read through the answers. I don't have the answers in front of me, so let's see. It would be the first answer. So again, TTP has no abnormal coag test, whereas DIC, everything was abnormal for testing. So the correct answer is APTT test would be normal in TTP, but prolonged in DIC. That does fit, and that is the correct answer. Hemolytic uremic syndrome is associated with, and so this one would be E. coli O157 is a good cause of that. The first answer there almost fit, except it's thrombocytopenia, not thrombocytosis. That's why that one didn't work. Neurological findings may be commonly associated with which of the following? So we pointed this out earlier. This would be TTP. And there you go. It's a lot of abbreviations to kind of sort through. Do your best that you can and really get to know those diseases that we pointed out in here. All right, so let's go to our other PowerPoint. So that last one was all about the quantitative issues, like either having a low platelet count or a high platelet count. This one is still on platelets, but it's qualitative. So something about the platelets aren't working well. So we'll just kind of skip through the objectives. So a qualitative platelet disorder, again, if your platelets are not functioning well, you're still going to get the same mucocutaneous bleeding, bruising, prolonged bleeding time because it's affecting your platelets. A lot of times it may be a normal platelet count. There is one or two in here that will still have a low platelet count, but it's not the platelet count, it's the function of the platelets. So in this function, it could be anything affecting the adhesion, the aggregation, or the secretion of their contents. Any stage of how that platelet works could be abnormal. So the first disease that we definitely need to learn is Bernard-Soulier syndrome. A lot of times you might see this as BSS for short. The problem with Bernard-Soulier syndrome is that platelets cannot bind von Willebrand factor, and that is because they are missing the receptor for von Willebrand factor. So the receptor on the platelets is called glycoprotein 1B95. So that is the receptor that von Willebrand factor binds to, and then that helps the platelets adhere. Remember, von Willebrand factor's role is platelet adhesion. Well, if you are missing the receptor for it to bind to, your platelets cannot adhere to anything. So as a result, what we would see, we definitely see that prolonged bleeding time because your platelets can't adhere. There's no way that they're going to clot then. You do see giant platelets in this one and thrombocytopenia as well. And then if you were to do what we call platelet aggregation studies, so platelet aggregation studies are tests that you can basically see how are the platelets functioning. They're a good test to assess platelet function. And so there's all different sorts of substances you can mix with that sample and determine does it respond the way it should or not. So you can mix in ADP, epinephrine, collagen, arachidonic acid. Those are all different substances that we are assessing are the platelets responding to them. In the case of Bernard-Soulier, you'd be fine. Those would all be a normal response. But when you go to add ristocetin, that would be an abnormal response. So it does not respond to ristocetin. So when we talked last week, we talked about von Willebrand disease. And I had said then, von Willebrand factor and ristocetin go together all the time. They're a cofactor for each other. So if you don't have the ability to work with von Willebrand factor, you're not going to respond to ristocetin in the testing. So it's always a sign of something's wrong. Now, in the case of Bernard-Soulier, we have enough von Willebrand factor. We're not low in that. You know, we were low in it in the von Willebrand disease, but in the case of Bernard-Soulier, we have enough von Willebrand factor, but because we are missing the receptor for it and it cannot bind, we will not respond to ristocetin, and as a result, because it's still not working right. So that is the issue here. So the main lab findings for this to assess that it's Bernard-Soulier is you'd see the low platelet count, the giant platelets, prolonged bleeding time telling you there's something wrong with the platelets. And then if you were to do platelet aggregation, everything would be normal except the ristocetin. And then that right away tells us something's going on with the von Willebrand factor. You could do a level, you could measure the von Willebrand factor level, and in this case you would see it's a normal level, so it's actually the receptor that's not working. So that is Bernard-Soulier. Here's a representation of what it would look like. You can note 3 giant platelets in that picture, no other platelets seen. All right, and then the other one that's you have to kind of differentiate between is Glanzmann thrombocythemia. So we're missing a receptor in this one on the platelets as well, but this one is called glycoprotein 2B3A. It's a receptor for a few things, but it's a major receptor for fibrinogen. So that is fibrinogen's receptor on the platelets. And remember, fibrinogen has a couple roles in our body. One, fibrinogen is huge in forming fibrin clots with the coagulation pathways. But as far as platelets go, fibrinogen is also big with platelet aggregation. So if you cannot bind fibrinogen to that platelet to help it with the clumping, the aggregation, it's not going to work. So as a result, we're not going to get the platelets to aggregate and clump together to finish forming their platelet clots if you are missing that receptor, and then you can't play with fibrinogen. So that is Glanzmann for lab findings. Totally normal platelet count, no giant platelets or anything here. The platelet count itself is normal, but again, the bleeding time is prolonged because they're not functioning. And then if you do the platelet aggregation studies, it would be abnormal response to ADP, collagen, epinephrine, thrombin. Basically, everything for platelet aggregation studies would be abnormal except ristocetin because the von Willebrand factor was fine and the receptor for von Willebrand factor was fine. So ristocetin would work fine here. But everything else would be abnormal. Well, if you think about it, if you don't have fibrinogen, you're not going to aggregate, right? So platelet aggregation to everything else would be abnormal. The other key test in this is abnormal in vitro clot retraction. So basically, fibrinogen has a huge role with platelet aggregation and the clot retraction process. So if you're missing the receptor for fibrinogen, you're not going to perform either one of them well. So those are the key test results to remember for Glanzmann. And then you have disorders involving your granules. So the granules and the platelets store things, and they store very important things to our clotting process. So we have dense granule deficiencies. So you have to remember that dense granules contain ADP, calcium, and serotonin. Basically, those 3 items are the 3 items I want you to know that dense granules store. If you have a dense granule deficiency where you're not having dense granules, then you're missing all 3 of these items. And these have major roles in helping activate platelets, aggregate them, you know, all that stuff, that part that they do. So we can find this with a few different disorders, or it can be a disorder all on its own. And then, which I think you can call that disorder, I don't know if it says it on here. It's called storage pool disorder if you're missing your dense granules, so just keep that in mind. The other granules called alpha granules, they contain a ton of things. They contain a bunch of different coag factors like fibrinogen, von Willebrand factor, some growth factor, you know, things like that. So lots of big things in our clotting process. So if you are missing those alpha granules and you're not having any of this stuff stored properly, this is what we call gray platelet syndrome. So again, platelets are not going to function well here at all. This is supposed to, every time I do this PowerPoint, I forget that I have this picture on here, and I always say, I need to change the picture. The platelets in here, we're supposed to be showing that gray platelet where you're not really seeing any granules, but as you can tell, the plate, it was really hard to find a picture. I don't even know, I should just probably remove the picture altogether because it's a dark picture and it's hard to see anyway. So just kind of ignore that. All right, and then you got other disorders that can affect your platelet function in general. Again, myeloproliferative, like the big one there would be, again, essential thrombocythemia. Even though you have like greater than 1,000 platelets in essential thrombocythemia, remember the platelet function was horrible and not working. So that would be an example of affecting platelet function. Excuse me, multiple myeloma, Waldenstrom macroglobulinemia. In those two disorders, there's an excessive production of protein, and they can kind of coat the platelets, and so it results in dysfunction that way. And then vasculature disorders, so vascular disorders. So remember, in your primary hemostasis process, it wasn't just the platelets involved, but also your blood vessels. So if there's something wrong with your blood vessels, that can lead to a bleeding disorder as well. Because remember, your blood vessels usually try to contract up and help seal the wound if they can. Well, there is one hereditary disorder called hereditary hemorrhagic telangiectasia. Telangiectasia is a hard word, which basically means that you have these really thin-walled blood vessels. And they just, because they're so thin-walled and all this, they're very superficial, dilated. You get these red lesions all over. They don't help seal very well. So it leads to tendencies to have more bleeding. Usually epistaxis, which is nosebleeds, is a common finding with anybody that has this. I don't really test you on this, so I'm not going to worry too much about this disorder. It's just a mention. And then there is an acquired one called Heme purpura. I always feel very German when I say that. I want to say it like angrily almost, German. Heme otherwise known as an allergic purpura. So it's an autoimmune type injury to the vasculature. I'm not testing you on this at all, so no need to worry about this at this time. But if you want to read up on it because you think it's interesting, please do. Amyloidosis. This is one that I know I think there's a House episode on this one. And amyloid, and I don't even watch that much House, or I never did, but I felt like there was one on this. Amyloid is a fibrous protein. Basically, you're seeing excessive amounts of this protein in amyloidosis. It damages the tissues, so that's why it's coming in under the vascular disorder part of it, if it's damaging tissues, damaging blood vessels, that kind of thing. And so, yeah, we're not testing on that one either, so don't worry about that one. These vascular ones are just mentions. They're not testing on. All right, some review questions. So we have some lab results here on a patient with a severe bleeding problem. So take a look at those, figure out what's abnormal. So when I look down it, I can see that we have a low platelet count. It's 125. That's less than 150. MPV, mean platelet volume. That tells us the size of our platelets. Well, if it's a size of 16, that's above reference range. That's telling me I have giant platelets. Your bleeding time is prolonged. Your PT and PCT are normal, and then platelet aggregation, everything's normal except the ristocetin. So hopefully you already have your answer, but this is a great example of Bernard-Soulier syndrome. And then the other case study here, you have platelet count of 256, totally normal. Bleeding time is prolonged, clot retraction deficient. That one right away there should point it out for you. And then aggregation studies, normal to ristocetin, weak or no response to the rest, so that one should be Glanzmann's thrombocythemia. So another good representation there of Glanzmann. Which of the following is a component of platelet alpha granules? And out of these choices, it would be von Willebrand factor, because remember, ADP, calcium, and serotonin are the ones in the dense granules. Which may be the cause of defective clot retraction? And this would be that receptor for fibrinogen, which is glycoprotein 2B3A, so the second choice there. Abnormal platelet function is a suspected cause of a bleeding problem in a patient who has a normal platelet count. Which of the following procedures gives information with regard to platelet function? So the only one of these that will tell us how our platelets are functioning is the bleeding time. Normal platelet adhesion depends upon, so we all know that platelet adhesion is all about von Willebrand factor, and the receptor for von Willebrand factor is glycoprotein 1B. It's technically 1B95, they just didn't write the full thing out. So glycoprotein 1B. Bernard-Soulier syndrome is associated with, and sorry, I don't have the answers in front of me, so I have to read through it. In this case, it would be thrombocytopenia and giant platelets would be the right answer out of the 4 choices. When performing platelet aggregation studies, which set of platelet aggregation results would most likely be associated with Bernard-Soulier? So remember, in Bernard-Soulier, it's only an abnormal response to ristocine. Everything else is normal. So this would be the second choice. Just the ristocine is abnormal. Which set of platelet responses would be most likely with Glanzmann? So in this case, only ristocine is normal, everything else is not, so it would be the third choice. Storage pool deficiencies are defects of, and that would be platelet granules. Hereditary hemorrhagic telangiectasia is a disorder of, so it's all about your vasculature, so it's your connective tissue. Which defect characterizes Gray's syndrome? And Gray's syndrome was the alpha granule defect. All right, so those are your 2 PowerPoints for this week. If you guys have any questions, as always, please feel free to reach out. Otherwise, have a great week, guys. Thanks.